Thank you for joining us for tonight's educational webinar on orthopedic outpatient surgery. Tonight's speaker is Dr. Mark Gittins, OrthoNeuro Orthopedic Surgeon. Dr. Gittins is a board-certified orthopedic surgeon specializing in sports medicine and arthritis with extensive experience in outpatient joint reconstruction, including robotic-assisted knee joint replacement and direct anterior hip replacement. Dr. Gittins will answer questions following his presentation. Please type your questions into the Q&A box at the bottom of your screen. Dr. Gittins?
Thank you, Heather. So my task tonight is to talk about outpatient world, and so the methods that we're going to use, I'm going to kind of speak to why it's occurred, what's happened with some of the political reasons on why this has happened and why we've done it. Then we'll talk a little bit about what arthritis is and why people are needing this. And then at the end, we'll do a short video, actually one of our patients that's gone through an outpatient procedure. So thanks again for being with us, and hopefully you're staying cool and hydrated. If you do have questions, as Heather said, don't be afraid to type them in, and I'll try to get them as we go through this to the end. So with outpatient total joints, it is an up and coming trend, and we've been one of the pioneers on it and done some of the original investigations on it and why this is good and why it's safe. And so the real reason this started to catch fire in the governmental world is because it's simply a money deal. It saved money. Now, we were doing these 9 years ago because we knew at that point that it's just simply better for the patients. They had better outcomes, and they were just doing better because of the surgery. But as a result of the Affordability and Accountable Care Act, which was attributed to Obama, the goal was to try to save some money. And so one of the ways that they looked at that was to do changes in the way that the Medicare, which would be Medicare, Medicaid, or CMS, that'd be the other term that you hear, basically interacts. So here's how the country is divided up. So we're with Wisconsin and Illinois and Indiana. That's our section. They're all compared to each other, but obviously New York and California are going to be different than us in the Midwest. What this technology did is it really kind of, with our CMS patients, looked at what was happening and how the dollars were being spent. And so we kind of had three new classifications of what the typical CMS, Medicare, Medicaid services were. And I was fortunate enough to go and actually testify on this topic to them. But we see the number one issue between what we call the young old patients, the younger people into the CMS, is that hip and knee arthroplasty, basically arthritis type surgeries, was accounting for 34% of all the healthcare dollars being spent in this what we call young old group, or the young people in CMS. When we looked at the people that were in the middle of the CMS bundle, again, some of those people got sick because of septicemia. You may have heard of that. Those are people in the ICU, so they have very long stays. But then we saw people, again, hip and knee replacement. So now we're up to the 84-year-old age group that's still having these issues. And then we looked at people over 85, and again, you're still, although some of those people get sick because their hearts wear out or get urinary tract infections, still a lot of people are spending dollars, although it's only 15% of the total amount spent in CMS with hip and knee arthroplasty. So the government, when we met with them, went through a number of things and looked at safety and efficiency. And so in 2017, the knee replacement was the first one to go. And so total knee replacements went to outpatient surgery. Now, what is outpatient? It's more of a billing issue than anything else for the hospitals and the hospital administrators, but it does mean that the patient comes in, has their procedure done, and goes home the same day. So that's what we're talking about when we're talking about outpatient surgery. So it really puts the focus on the procedure, the anesthesia, how safe it is, and how fast we get people back into the rehabilitation. So in 2017, we started doing full total knees. We were already doing partial knee replacements prior to that. And again, we've been doing this going into our 10th year. What also came out of that study is in that 2020, now the hips are outpatient. So as we speak right now, the hips are done in an outpatient fashion where they come in, they have their surgery done, and they go home the same day. That will be done in the surgery center, probably, just kind of guessing how Medicare CMS works, probably in January of this upcoming year. It'll flip over that all these will be done in surgery centers and the outpatient areas of the hospitals. So that's what we've kind of seen, and why this is so an important thing. So it's putting a lot of pressure on the hospitals. It's putting a lot of pressure on the consumer, which is the patient, and the surgeons are having to step up to try to meet this. But I think fortunately the surgeons have been the driver of all this, and we've seen better outcomes. Patients are doing better. They simply have better outcomes, use less pain medicine, and are happier with their procedure. So when we talk about arthritis, a lot of people come in and talk to us, am I a candidate for surgery? Do I need surgery? What really is osteoarthritis? I was talking to numerous patients today, and basically osteoarthritis is the number one cause that we see. Over half of America is affected at some time during their life with this degenerative bone disease. It's the most common cause of disability, and we're seeing over 50% of the United States people with this. Obviously, the U.S. has certain things that accelerate that. Certainly, our issues with some diabetic issues and metabolism issues with obesity that we may accelerate this. But just like any other type of disease, there's somewhat like mild, moderate, severe, and you can see the pictures on the right, and it's just a wearing of the cartilage on the end of the bone. So if it's just a little bit worn, then we'll call that mild. And again, those people may have started with a sports injury when they were in high school or in cheerleading class or something like gymnastics class. As they go through life and they progress, well, then they wear more of the joint off, which you may see here. Therefore, they may lose a little bit of motion. They may not be able to run as far. They have a little bit more pain. What we as surgeons look for is the pattern. What is the pattern of arthritis? Is it all in one area? Is it in this area? Is it all the compartments of the knee? How's that affecting the person? As this progresses, and again, there is no cure for arthritis. It's just how do we live with it? How do we deal with it at this point? Again, we see a lot of disability. People can't do certain parts of their job anymore. They have pain at night. They get swelling. They have difficulty going up and down stairs or have to use the rail. They have trouble getting out of a chair. And again, what's happened is usually the arthritic pattern has disseminated itself across the whole joint. So the treatment, as you can maybe guess, mild, moderate, and severe is different. And so when you have early changes, so the mild, we want to make sure that if we have a weight challenge or metabolic issue, that we're controlling that and pushing it down as far as we can. Those people are usually helped with simple anti-inflammatory medicines such as Advil or Aleve, and you can buy those over the counter. Tylenol works really well with those too, so that's something you can add to the anti-inflammatory medication, is simple Tylenol. Trying to stay active is a good thing. So we usually recommend perhaps maybe not running, but more cycling, water therapy, dance therapy. Those are things that include rhythm and balance and strength, and that is what we start with, and usually the mild areas. On the moderate side, then you can consider doing some lubricant injections. Some people still use some corticosteroids, although the literature is somewhat pushing a change in that, and that we're not seeing as much corticosteroid use as we did in the past. And then again, if people have failed those, been through therapy, done their exercises, used their anti-inflammatory medications, and they're still noticing a change in their activity level, then those are the people that surgery can be beneficial. But that's how it is usually progressed, depending on the disease and how the disease progresses. Again, these are just some of the options that I mentioned. Again, probably the most common are the Advil and the Aleve. The steroid injections, the cortisone injections, still occasionally used, but we are seeing some. It used to be our gold standard because that's all we had, but it may have some deleterious effects to the joint. Braces are something you can use. TENS unit, again, are not harmful. They kind of block some of the pain. Stem cells, you may see some of that on TV. Again, we're not seeing a lot of FDA approval on that at this point. Hyaluronic acid or lubricant or chicken injections, that's what is able to do. Again, it just has to be cleared with your insurance. So those are some of the things that we can do for the mild and the moderate levels. And again, with these mild and moderate, depending on your age and depending on the type, you may be a candidate for a scope, especially if you have mechanical symptoms such as locking or catching, such as a torn meniscus in there. So that's usually for younger, mild patients with arthritis. But as you progress, then, as I was saying earlier, you may be surgical. And the surgical things are, again, the more severe states where you've worn the hyaline cartilage completely off, and you get these raw pink spots, which is really bone. So then you may hear the term bone on bone. And that's what's happened. You've worn the cartilage and you simply get bone on bone. These photos just demonstrate some of the techniques that we use. We have all kinds of scans, whether they're CAT scans or MRI scans. And now the big push is that most of the companies are having some type of robotic work. We're able to use a robot to help reconstruct the joint where this wear of the cartilage down to the bone has occurred. Again, we see really excellent results in knee and hip arthroplasty. And these are basically, we're seeing, what we think of as lifelong results. We try to get these in and last 20, 30, 40 years. So you want to try to make sure you're working with people that do that many, that are used to participating in the programs and have a program for doing this. The partial knee replacement, again, you have to be the right person with the right pattern of arthritis for that. We certainly now know, if you look at some of the joint registries out there, that the partials tend to do much better for the majority of surgeons doing them if they're using some type of robotic instrumentation to put them in. The accuracy, the reproducibility is much higher. Therefore, the outliers are much less. This is what it looks like when you do things with a robot. You can see how everything lines up perfectly straight. So this is what a partial knee replacement looks like. Therefore, again, we're more accurate, we're more reproducible. So each case looks like the next case as far as getting the leg aligned. This is one of the machines that we use. This is what's called a blue belt, which is now moving forward to what's called a CORI. The names are important really only to the surgeons, but it shows that we start thinking in different types of precision and accuracy. So now we start thinking in half millimeter and half degree increments. So that's 20 thousandths of an inch. So extremely accurate that we're able to align joints and get them very, very straight and erect, with the tracking and the pressure on each side of the joint being equal. This is how it looks. As you can see, these high-speed burrs, they spin at about 80,000 RPMs. They connect with the robot and the computer, and it basically gives you a custom knee just for your leg. This is an animated version of what that may look like. And so this is what these outpatient cases look like in hip and knee arthroplasty, where the patient's there, the robot comes in, we're able to show what the knee looks like real time. So we don't have to take any special x-rays. We're able to see how the joint's going to actually move. You can see the pictures there before we even do the surgery, and then we're able to adjust the components to make sure that it fits just perfectly to you. Again, making adjustments within 20 thousandths of an inch. This is then registered on the tip of this cutting device, again, which is going in and out. It's very safe. It's very reproducible. So we're fortunate enough to have a lot of visitors come in and see us and try to replicate this program. But this is how the worn piece of portion of bone is just simply sketched out. And then the worn, very hard bone is then simply removed, and the cutting device is able to put these in exactly perfect to fit each person's knee. Each case is done differently. And then these pieces are just cemented onto the knee. And with that, the patients are able to get up and walk and go up and down steps and go to the restroom. And usually they're out of the center by lunchtime. So it's a very smooth procedure, and people are able to recover at their own home. And again, this is just some of the technology. It's very much driven with the technology and the math of all these surface contact points that we're able to put into the robot. And then we have all these colors that help the surgical team know exactly where they're cutting to get this leg aligned perfectly. A lot of questions that patients ask, and we'll go through these as we go on, does this allow for shorter stay? Yes. Does it control blood loss? We think yes, because we're not doing as much. We're able to use smaller scars. And then we think we get people back to their lifestyle pretty quick. So, we're seeing most of our patients in less than 3 weeks, back to work, going golfing, that type of stuff. Not everybody, but most. So that's what we see as far as what arthritis is and what's happening. So this last little video is one I want to show you. And it's one of our patients that had an outpatient hip replacement. And so when people say, what's outpatient? So what we've talked about is that it's something that we've been doing for a long period of time. CMS has just started in the last few years, first with total knees and now with total hips, bringing this into the realm where it's basically almost required unless there's certain medical conditions for all of our people. So here's one that I'll let you watch, and you can enjoy this journey of this patient. Please.
Well, I have had a history of orthopedic problems in my lower limbs for a long time. When I followed up with Dr. Gittins, then I found out that arthritis had really started affecting my hip as well. Gradually, I had just, been less active. And then a couple of years ago, I retired. And so now I want to be able to do the things that I want to do when I want to do them. And it's just not as easy to do that right now.
Being an outpatient, there's a lot of benefits to it. And you're in and out. You're back in your own comfortable bed or back in your home. And so I think, the healing process just is that much easier for you when you're at home.
Hey, I'm all for outpatient. Yeah. What I'm expecting today is to go home for lunch, and I think everything will go very smoothly. And I've been looking forward to this, so I'm ready to get it started.
Just to recap what we talked about in the office, anesthesia will be in, Dr. Betts and his team will be in just a little bit. They're going to talk to you about a number of different things for this. We just completed the right toe hip on an outpatient basis. Everything went smooth.
Okay, I'm gonna switch up a little bit. You did great. How's that hip feel? You having any pain? Surgical leg, then good leg. Okay. So we're gonna go up with the good. Yep, here, good. Again.
Superstar. I love it. A+. Excellent. Good.
I'm not at all hesitant to go home and think that I'm going to have any kind of a medical emergency. They did not push me out the door when I faltered a little bit. They just held steady right there until I was ready to go to the next step, and that's what happened. I'm looking forward to going home, getting comfortable, and just letting the recovery start.
So we will go to some questions now. So I think, let's see, where am I here? Am I still there, Heather?
Yes, you're still there. If you stop sharing your screen, it'll pop you up, and I think you'll be able to see it better.
Just needed to pop up myself. Good. Glad we're there. All right. There we go. All righty. So that's just a kind of a hint of what we're doing and what outpatient is, because it brings all kinds of questions of what outpatient really is. And So I'm going to go through some questions here, and that will probably spur some other questions, but we've see this usually be a valuable thing. So what age, one of the questions, what age do people typically start experiencing arthritis? And, it really is a genetic issue. And so if your family is prone to it, you're going to start seeing it earlier. If you have an injury, like an athletic injury where you tear your ACL or you lose a meniscus, those people are going to get it sooner. Some people never get it, but we do see, over half the people in the United States do get it at some time. So you really can't change your genetics, but what you can do is, live a healthy lifestyle, eat a good balanced diet, try to have a good exercise program. Those are the things that we can see. Keep weight challenges to a minimum. Those are the things that we see tend to give people the best shot at not experiencing arthritis during their lifetime. Another question is what determines whether you get a partial or total knee? Well, I think it's a great question, and it really depends on your surgeon and what they're comfortable doing. That's one factor. Some people are not comfortable doing partials. It's a more finicky, it's a more difficult procedure. The other thing from the patient standpoint is what type of arthritis do they have? Do they have an inflammatory arthritis? Is their ACL okay? What is their pattern of arthritis? Where is their pain? So I think you need to talk to your surgeon and look at your x-rays. We have seen an uptick, especially with the robotic world, of partial knees coming on board, although a lot of the totals now are done with robots too. Another question is, can I choose to have the surgery with the robot? And that would probably be similar to what I said on the first one. It depends on what your surgeon's comfortable with and whether there's a robot at the facility. Not every facility has one, and what type of robot they have. And robots are, they're just a wonderful computer, but you still have to have, they're not going to replace surgeons. You still have to be careful. You have to know how to use them. They can get you in trouble, as well as not having a robot can get you in trouble. So again, I usually ask people, make sure that if you're doing that you have somebody that has experience, that's used to doing them. Ask questions, be a good consumer of your healthcare. But there are a number of procedures that it is beneficial. How long does a total knee replacement take? So, I think usually around an hour, 45 minutes to an hour is about the amount of time that it takes. So it doesn't take, again, with all the planning that's done prior to surgery, the surgery itself should be, pretty smooth. It should be, almost like a dance, a 1, a 2, a 3, and the steps are followed, and it should be pretty smooth. And the idea with this whole outpatient world is to have that coordinated with your anesthesia team, because there's different types of anesthesia that we use. And if you do that, have a coordinated team, then you're able to get up and walk. And you saw the illustration that we have, people are doing stairs within, an hour after surgery. So it's amazing how we can get these people with the hip and knee replacements back up and moving so quickly. So part of it's your anesthesia team, part of it's having a team that's used to doing outpatient work. Some people are still learning how to do it. We have a lot of visitors that are at that level. So again, if that's where we're at, just make sure again that you're asking questions and you know how many do and what kind of a day it is. What can't I do after a knee replacement is another question. And I don't put a lot of restrictions on my patients. I think you got to have realistic expectations of what you can do. I don't see many people coming in that are candidates for knee replacement and like wanting to run marathons and such, because they usually have some other body issues as far as they have arthritis, maybe in another joint that's not quite ready for surgery yet. So things like that, running endurance races. But I have people that bike and ski and do endurance bicycle racing. It's usually the pounding type exercises that I encourage people maybe to look at different options there. But they can ski, they can hike, they can golf, they can dance, they can speed walk. So I really don't put many restrictions at all. The reason we do the surgery is so people have an active lifestyle. That's when you start seeing that you're losing some of your lifestyle, you can't do stuff with the kids, you can't go golfing, you're hurt at night, you can't do the stairs, you can't keep up with your spouse or whoever you're walking with, then that's when you really need to have an evaluation to consider options that may be best for you. What other surgeries are now being done outpatient? Shoulder replacements and spine surgery were the questions. And so again, it's a great question. And it goes back to, I'm glad we talked about some of that. It really goes back to the insurances and what's allowed. But CMS now is allowing, like spine surgeries, certain spine surgeries, not all, to be done outpatient. And again, the reason is because if the team is coordinated with their anesthesia and the surgeon, we're seeing better results with the spine surgery done outpatient. So certainly some of the spine surgery is done. Shoulder surgery is done a lot outpatient. So like rotator cuff repairs, even fractures, labral repairs for dislocations, that's all done outpatient. CMS at this point has not allowed total shoulder replacement in the outpatient arena yet. Although the private insurers, so you think of private insurers, something like Anthem, UHC, MMO, Medical Mutual of Ohio, we call those the private insurers. They do allow them to be done outpatient. So it just depends on your surgeon's comfort, your comfort, the anesthesia, and what insurance you're having. So that's what we're seeing in the outpatient world. And again, it certainly has opened up. There was a big push in the outpatient world once the pandemia that we've all been living through was there, because nobody was going to a hospital, but the arthritic disease was not going away. And so lots of people are going to the outpatient world. Fortunately for us and a number of other people, that had been doing it, it was nothing new. It's just business as usual. For some people, they had to learn how to do it, and their centers had to learn how to do it. So there was a little bit of learning curve. But what we're seeing is that trend is not going to go away, and it's probably going to increase, where you'll see, probably close to 70%, 75% of all the surgeries going to the outpatient world, because we do have a coordinated team. We have protocols. Anesthesia works well with the surgeons, the recovery room staff. So I think there's a lot of benefits to doing it this way. And I think we'll see more of that expand, especially as we get some newer medications, newer techniques that are always expanding. But I think we're doing really pretty well with it right now. Let's see. I'm looking for the last question. Does osteoporosis interfere with a successful outcome? And that's a good question. So osteoporosis sounds like, and when you listen to the word, sounds like osteoarthritis, but they're two separate diseases. So osteoporosis is really, thinning of the bone. And so that's different than osteoarthritis, which is wearing out of the joint. People can have very, very good results that have severe osteoarthritis and have osteoporosis. So there's not a direct correlation. They're two separate diseases. And you can have osteoporosis and not even have arthritis. So it's something that you factor in as a surgeon, because you're only as good as the quality of bone that you're working with. But there's ways to get things done and keep the two diseases somewhat separate. But that's really the definitions of the diseases. Are there any other questions that we're seeing?
Did you answer what would eliminate me from being able to have outpatient joint surgery?
Oh, I skipped it. Thank you so much, Heather. I just didn't see it. I was trying to go down here. What would eliminate me? So we kind of have a list anymore of who's not a candidate, because almost everybody is a candidate. And the term that goes with this is you need to really optimize the patient prior to surgery. So you just don't take them to surgery. You look at what the surgery is, you look at the medical conditions, and then you alter those. And so the list of things that don't go to surgery, somebody who's on dialysis, because most outpatient centers don't have a dialysis unit there. Somebody who has 24-hour-a-day oxygen therapy may not be a good candidate. People that have had solid organ transplants, so somebody with a kidney transplant or heart transplant, they might not be good outpatient cases. So there are extreme things like that. Diabetes that's under control. We just say, well, you just need to get the diabetes under control. We can get the specialists and the endocrinologists to help us out with that. So those are the people that are not candidates for outpatient. So other than that, again, you optimize the patients so that they can get there. So having coronary stents or having a previous heart attack don't disqualify you from having outpatient surgery. Having a blood clot does not disqualify you. You just have to talk to your surgeon and know the protocols on what you can do and what you can't do with that. So hopefully that answers it. Most people are, but the ones, like I said, dialysis, 24-hour a day, oxygen, solid organ transplant, that type of things.
Thank you. Do we have any additional questions? I have a question for you. You always say you'll know when you know, as far as when to have surgery. Can you expand a little bit on that?
So when we say that, it's really the patient's choice. These are really elective procedures, right? I don't tell people you have to have surgery. When they get to the point where they're losing function in any fashion, then it's time to have it. There used to be, well, you have to be 55, you have to be 60. So I think we're robbing people. Life's short. You never know what's going to happen the next day. So I think if you're having loss of function, you're having discomfort, and your X-rays show that you're an osteoarthritic person, then if your surgeon's recommending it, you might want to consider it. But when I say that, some people's like, well, I never had pain, I'm just uncomfortable. Well, to me, that's however you want to decide. So I would look at anytime I can't walk as far, I can't walk as fast, I'm hurting at night, I'm taking more pills, I'm stiffer, I can't get into my car as well, I'm having trouble getting out of a chair, I can't get off the floor, I'm afraid to babysit the grandkids because I don't know if I can keep up with them. I hesitate to go to the zoo with people because of the walking, or I can't go to the fair because of the walking involved. So that's what I mean by when you know. It's just you don't want to just masquerade it. The options to solve the issue of the arthritic pain are so good now. There's just no reason to wait anymore. My dad just 2.5 weeks ago went through a revision at 86 years old, so he can play softball 3 nights a week again. So that's where I come from. That's living life. I think that's what you want to do. So you just don't want to be tucked in a corner and not being enthusiastic about life and being able to move. It's all about moving, and arthritis is a curse that takes that away. So that's what I look for on that.
Thank you. Any additional questions?
Well, the one thing I'll leave you all with is a request and something for fun. Heather works in multiple jobs, and so do I. And so at OrthoNeuro supports research and a number of the universities. And so one of the ways that we collaborate with research is through something called the Orthopedic Foundation. And the Orthopedic Foundation has been works tirelessly all year long about doing research for neurological diseases and orthopedic disease, and it's currently going on. But this year on September the 19th is a big fundraiser for all arthritis research. So I invite you to come and participate in that fundraiser. You can look at the website, the Orthopedic Foundation. That's what it's called, the Orthopedic Foundation. It's a website. We'll have some special VIP guests that have had arthritis. We'll have some VIP announcers, and it's a polo match, a fun get-together match with all the community. On September the 19th at the Brindu Mansion in Granville. So look for that website and come out and say hi. Heather will be there. I'll be there. I'm hearing that some famous mascots might be there. So I encourage you to all come out if you get a chance and have just a wonderful time. It's a great, if you've never seen anything that crazy, it's a great, exciting sport, but it's even a better cause. I mean, to do the research, you see the people that you're impacting by supporting it. It's a great thing. So I'll leave that one promotional thing with you all.
Yes, come out and watch Dr. Gittins on the ponies.
That's scary.
Thank you, Dr. Gittins. Thank you all for participating in tonight's webinar. Our next webinar will be held on August 4th. Dr. Ralph Napolitano, ortho-neuro podiatrist and wound care specialist, will be speaking on foot pain. Enjoy the rest of your evening and good night.